Good morning to everybody, and thanks for your statement. Obviously, we shouldn't be having this meeting because it's a perpetual kind of cycle that we have a constant crisis in our health service, and particularly at this time of the year. And some of the scenes that people have to endure when they go into ED departments across the country, and the staff that have endured that as well, is completely unacceptable. And anybody that kind of, looks upon these extremely kind of stressful situations where people find themselves in, where, it's their mothers or fathers or brothers, sisters, find that in a very, very wealthy country, the health service continuously gets it wrong in relation to this section of healthcare. And I think it's important to say, look, the Irish health service in general is a very, very good health system once you get into it. There's some amazingly dedicated people, but this perpetual cycle of a situation where people are left on trolleys for days, and kind of it's just not acceptable. So my questions are, and we all understand there's tremendous pressures on all health services across Europe. There is kind of a number of factors that are unprecedented. We understand that, but there is a precedent, and the precedent that this keeps happening every year. So why does it happen every year? I mean, there's obviously, obvious circumstances why it keeps happening every year. There's lack of capacity. I think there's a fault in relation to management, in relation to how they did not make provision for this. Every single year it happens, and why does it happen? So that's what people listening today will want to know. Why does it continuously happen, and what are you putting in place for why it won't happen on a continuous basis?
So definitely you're correct. It is a perpetual cycle. It is a problem that happens, unfortunately, in this country and others every year. We're not making an excuse. This year is worse than previous years, but the conditions are different in terms of the respiratory illnesses that are circulating. But that doesn't take away from the fact that it is unacceptable, both for staff and for patients, and it has happened every year, certainly since I was in the health service. Now, what's the way out of it? Why is that the case? Effectively, as we know, as Sláintecare tells us, the health service is the wrong size and shape, so it doesn't help us in the next 3 or 4 weeks or next year or two. But we are on a journey. It is called Sláintecare. Government is investing in terms of the different components of that, and will need to keep investing in order to ensure the system has sufficient capacity, but sufficient capacity in the right places, starting out in the community. That's why more of the investment has correctly gone into the community area and into general practice, as well as investing in hospitals. It's also about better integrated care, which again Sláintecare talks about, moving to the 6 regions, and the piece that's probably maybe not as visible in Sláintecare, improved systems thinking. We do need to get better at the overall operations management of processes. Difficult to do when you don't have sufficient capacity or staff, but essential nonetheless. So no one of those things will resolve it. And
it isn't. While it's the same crisis that we face, we're not dealing with the same problem every year. If you look at our demographics, we had just over 400,000 people over age 65 in 2011. Now we have over 700,000, and 1 in 7 people now are over 65 years of age in Ireland. By 2050 it'll be 1 in 4, and it's in a sense we're dealing every winter with a moving target, and that the moving target is us as a population as we get older and depend more on healthcare services, which is why the solution can't be, and this has been identified, whatever flaws there were in the acute hospital capacity review of 2018, we can't rely on building acute hospital beds alone. We must build a health service that's attuned to the needs of a population that's getting older and is more reliant on healthcare services. Without doing that, we'll just be building beds in the acute sector to catch up with the population, a race that we will never win.
And we all understand that. I mean, 40 years ago, there was more beds in the public health service than there is now. So, I mean, that tells you everything, really. So, just in relation to the National Crisis Management Team and the Winter Oversight Group, and obviously you convened this on the 22nd of December for the reasons that you outlined. How long would this kind of amalgamation meet? How long will this kind of crisis management continue to meet in relation to the ongoing crisis?
It'll continue definitely for the foreseeable. We tend to talk about, till the end of March. We would expect, influenza, are we sure yet that it's peaked? It's kind of giving indications that it's peaked. It'll spend a number of weeks high, before it starts going down fully. It'll still be high for a number of weeks. So that'll take us definitely to the end of January and into February. So end of February into March, one of the things we're thinking about is what will be the triggers that will cause us to say, we can stand down the National Crisis Management Team, and because while it brings focus to one particular topic, obviously it can take focus away from elsewhere. So at least till the end of February will be the answer, probably into March.
Okay. With that, Deputy, briefly, if we look at the flu season this year, it started earlier, it's been climbing for longer, and it's peaked higher than any for many years. And flu seasons can go on, not just to February, March, but sometimes to early April. So while it seems to have peaked now, and it'll take another week before we're certain that it's peaked, it will take some time before those flu figures fall down along with the COVID-19 to levels where the unscheduled care pressures that we witnessed in the past few weeks, it won't be nearly as severe.
And has this amalgamation of the two, the Winter Oversight Group and the National Crisis Management, has this been activated before in the previous winters?
So, Debbie, the Winter Oversight Group is effectively the national operations team that Damien, as Chief Operations Officer, is in charge of, focusing particularly on winter. The crisis management team is effectively the overall management team at the HSE, with some additional kind of expert colleagues, again focusing on the same topic. During COVID is the most recent example of a similar. We have different crisis management teams that they're not all chaired by the CEO. It depends on what the crisis is and where it is. But for whole system crises like this, COVID was the last example when Paul Reid would have chaired the crisis management team, which would have sat for a number of years in effect.
And obviously the crisis management team gives you powers or provision to instigate all the things that you've said that the HSE would do in relation to activating, or reacting to a crisis.
Effectively, Chair, it doesn't actually, Deputy, it doesn't actually give you any powers. As CEO, I have the authority to, use the resources of the health service within the normal bounds. It simply gives more focus. In that it focuses on a single topic, in this case the crisis that the symptom of ED overcrowding, which we know is a wider health system problem, and it's a kind of a single item topic, and it's a question of focus and bringing together both the national management team and other experts, such as public health experts and colleagues. So it doesn't convey any additional powers, it conveys additional focus and urgency. It's the last internal governance piece we have to kick in order to respond to a particular issue.
And obviously you think it has, by instigating this, it has addressed or continues to address the crisis that we're having.
I think it continues to be appropriate, Deputy. I'm not suggesting that just standing up a group that one person chairs makes all the difference. It was necessary. Some of the actions that flowed from it may or not have been kind of decided upon or implemented as quickly had it not existed, and some of those have been part of what's made a difference. But as I said earlier, it's difficult to pick apart which one measure, decision, action process has had the biggest impact or the total impact. That'll be something that'll become clearer as we get more data over the coming weeks and months.
And if I just might add to that, I mean, it was one of the learnings from COVID as well, that approach had advantages in terms of pulling everyone together in terms of whatever the crisis is. In that case, it was the pandemic. In this case, it's the current pressures in the emergency department.
Just my final questions in relation to private health or private hospital capacity. 180 beds have been assessed for private hospitals. Is there more room for capacity in relation to the private sector?
Yes, definitely. So we went through their overall numbers earlier on. So while the number is a very big number, 2,200 beds, if you discount sites that don't do the type of work we're talking about, discount the 600 public beds, there's about 1,450 beds potentially. Now, most of them are focused on surgical work, not on medical work. So the fact that we have 180 means we've got 12 or 13% of the real capacity in terms of inpatient beds. We're pursuing more. There's another kind of 50 plus beds that if we could get, that we might be able to get. We would take as many as we could appropriately get, but eventually the private hospital system runs out of either the staff or runs out of spare capacity because it also has other work going through it, or appropriate types of staff. So they don't have large amounts of critical care beds, for example. They don't have large amounts of physicians,
right.
And in some cases we end up trying to provide kind of clinical support to get access to beds.
Okay, thanks. And what were the 180 beds in the private hospitals? What were they I suppose, evaluated for in relation to patients coming from?
Largely for urgent and time-sensitive care, so maybe some cancer procedures in some cases, or in some cases actually for unscheduled care patients, some of whom would be medical patients, some perhaps maybe orthopedic patients. It just depends on the public hospital, the patients, and the private hospital and its capacities. Colin,
Just briefly, it's worth pointing out that beds in private hospitals are not akin bed to bed like a public hospital system. The public hospital system can easily flex to dealing with unscheduled care, as you've heard about surge beds and displacement of elective activity. The private hospital system, while it does deal with some unscheduled care activity, is largely configured to dealing with procedures, episodic healthcare, of course some complex healthcare too, but the public healthcare system much more easily flexes towards dealing with unscheduled care at scale in comparison with the private healthcare system.
Thank you.
One other point, Chair, but just on private beds as well, community beds are another important part of that. So we purchased what are called transitional care beds for up to 10 weeks. So this is where someone is going to have to go to long-term care, and rather than stay in the acute hospital, we purchase that bed so that person can go through the fair deal and all of the medical assessments and so on before moving to their new home in a nursing home. So that's another really important. Over 600 of those beds are utilised through that period as well. So that's a really big number that facilitates that flow from hospital that we talked about earlier.
Thank you.